So I'm going to be presenting, as Jacinda said, on some priority data gaps for quantifying the impact of novel syphilis interventions. There is also some HIV modelling in this. So even if you came to this session only interested in HIV, I hope you'll leave this presentation happy. Okay, so let's see if the clicker works. Do I have to turn it on? It does do something. Okay, so I'm going to start out with what we do and don't know about syphilis. Starting, oh gosh, it's very low res, which I'm sure is also my fault. So again, what we know about syphilis is that the burden of syphilis, even if I take the walking microphone, the burden of syphilis is both substantial and increasing. Within even just looking at STIs, so there's around 1 million new STIs acquired every day globally. And syphilis, I mean, this little bar chart here is supposed to show you that even though syphilis is a really small proportion of the total number of STI infections that are acquired, it makes up a really significant portion of the STI related DALYs, disability adjusted life years. And this is almost entirely because syphilis transmits maternally from a pregnant woman to her baby. And that burden of congenital syphilis makes up the vast proportion of what we see there in terms of that disease burden. This is so much the case, in fact, that according to one analysis, syphilis is estimated to account for around 8% of preventable stillbirths. This puts it about on par with malaria, which is the largest cause of preventable stillbirths, and significantly higher than HIV. I can't remember, that was 1 or 2%, a little higher than NCDs. So it really has a substantial impact on what we think of in terms of adverse birth outcomes. So it's obviously something that we're all pretty interested in avoiding. We also know that syphilis is trending really sharply higher, especially in higher income countries. I've just pulled out a few key stats from reports from the US, UK, and Canada showing these really astronomical increases over the past few years. We don't have similar figures coming out of lower middle income countries yet, but we could potentially see that this might be a trend that would be spreading globally going forward. So despite these increases in higher income countries, the majority of that disease burden that we see in terms of the DALYs is still concentrated in lower middle income countries, particularly across sub-Saharan Africa. Okay, so what else do we know about syphilis? Okay, sorry, it's spoiling my punchline, but that's all right. We understand the basics of how syphilis progresses and how to treat it. It's very easily treatable with benzathine penicillin injections, and treatment is very effective, especially during pregnancy, which really averts those kind of negative outcomes from the congenital syphilis transmission that we were speaking about previously. So this figure here, I've cut off the X and Y axis to make it easier for you to read. But the main point that you need to take away here is that this is from an analysis, it's a meta-regression looking at 128 countries and analyzing the cost effectiveness of interventions across HIV, TB, malaria, and syphilis. And that, that green bar at the top there, that's the cost effectiveness of syphilis. So it basically came out lowest of all of the different interventions across those 4 diseases that they were looking at. So it's an extremely cost effective intervention to treat syphilis, particularly during pregnancy. Okay, so that's what we know, that it's a big problem, it's an increasing problem, but we know how to fix it. But there's a lot we don't know. And what I really want to focus on today is we don't really understand very well how transmissible syphilis is by stage of infection. So this figure here shows approximately the kind of progression of syphilis from infection through to primary syphilis, which is characterized by genital ulcers, to secondary, where it's a disseminated rash. And then there's a progression to early latent syphilis, which is asymptomatic, and then late latent, also asymptomatic. And then years or decades later is where you get complications from tertiary syphilis. So it's kind of long understood that in those yellow boxes, the primary and secondary phases, people are very highly transmissible. They have a lot of bacteria at the ulcers and through the sort of mucosal sites as well. But what we don't really know is how long people remain transmissible for throughout, especially that early latent phase of syphilis infection. And I mean, when I was speaking to various, I'm not a syphilis expert, right? I started developing these syphilis models just in the past year or so. And as I started consulting with different syphilis experts to understand how to parameterize these models, one thing I was really surprised by is, syphilis is a really old disease. It's one of the first diseases. And yet there's still so much that we don't understand about it. So these experts were telling me, if you're looking at a paper that's more than 20 years old, then that's probably already out of date. There's been a lot of recent studies looking at people with latent infection which have detected bacteria at mucosal sites. It's not yet understood whether that's like some people are infectious some of the time, all people are a little bit infectious all of the time. And those differences would make a huge difference in terms of the disease dynamics. So that's kind of what I want to estimate, or what I want to investigate in these analyses here, is to look at, if we look at different assumptions around the duration of latent infectiousness, what does that mean in terms of our epidemic? And how might that mean we assess novel interventions differently? Okay, so I'm going to use mathematical modeling to do that. Gosh, slides look better on my computer. Anyway, we know that there's a strong use case for improved syphilis control, but the value depends on these factors that we don't know about latent transmissibility. And some of the questions, the one I'm going to focus on is in bold. So what are the use cases for novel point of care diagnostics? But there are other questions you could imagine as well that you might want to investigate in order to think about better ways of controlling syphilis. We also know that better data helps quantify value, but we want to understand which data are most important for us to collect, because as anybody who's ever done fieldwork would know, it's very expensive to collect data. So just in this little schematic here, we can use modeling to help us prioritize and focus data collection efforts. So I've got two examples here. In the top, we can think of an example of a piece of data that you might like to have for your modeling. And if you assumed that it was a low value, then you would get a cost-effective intervention, and you might fund vaccine development. And if you assumed a high value, you would also get a cost-effective intervention. So in that case, perhaps collecting that particular piece of data is less important, because no matter what data you got, you would still proceed with the same decision. But in the bottom here, this is an example of a very important missing input, where if you assumed, say, a low value for some parameter, then you might say, well, this doesn't look cost effective, I won't fund this particular innovation. Whereas if you assumed a high value, then you would. So that would be the kind of an example of something that we would really say, well, that's a top priority piece of data that we want to get so that we can make an informed decision here. Okay, so I'm going to the aim of this work is to kind of look at investigating the value of improved data on syphilis transmission dynamics, focusing on that latent transmissibility piece, since this could help us to inform data collection and improve delivery strategies. I'm going to be presenting a simulation study, which is using an agent-based model of HIV and syphilis co-infection. The reason for using a co-infection model is because there's a lot of interdependencies between syphilis and HIV. So I wanted to be able to capture the impact on HIV of improved syphilis control, but also you're leveraging there's a lot more HIV data than there is syphilis data. So if we include HIV in the model, then this means that we have a lot more data to calibrate the model to. And since we really want to investigate some of the uncertainties in our understanding of syphilis, if we can kind of fix as much information as we can by kind of hooking it onto what we know about HIV, then that gives us a little bit more freedom to investigate those syphilis parameters. And the study we're investigating in Zimbabwe, which is a data-rich setting. There's been a lot of, I'm sure anyone here who's worked in HIV knows there's been a lot of work done in Zimbabwe in terms of collecting HIV data as well as behavioral data over time. Okay, so I'll give you a very brief overview of the transmission model, and this is something that you are all welcome to ask questions about, because I don't have time to go into a lot of detail. But it's an agent-based model where we've built up a kind of risk and age stratified sexual network, and then put on top of that sexual network a very simplified HIV model. So the simplified HIV model is captured here. There's acute HIV infection, followed by latent, then late stage, and people can kind of go on and off treatment over time. And then we use CD4 counts as the kind of primary marker of a person's sort of progression through HIV. And these curves here are just showing how CD4 counts reconstitute once a person initiates onto treatment. And then there are dynamics that bring that CD4 count down once they go off treatment and progress through different stages of HIV. Okay, so I mean, when developing this model, that we had the advantage of having a lot of very experienced HIV modelers who could kind of help us to anchor some of these inputs. And make sure that we had a model that was kind of as simple as we could get away with, since HIV wasn't the primary focus of this, while still capturing the things that are important for HIV transmission. Okay, so the model is implemented in the StarSim software. If you came to the Lunch and Learn session today, then you already heard a little bit about that. But if you want to learn more, then on Thursday we have a StarSim Learning Day. So you can come and see a lot more details about how a model or an analysis like this is implemented. But we build it all up in the StarSim software, this sexual network with HIV, and then we calibrate HIV transmission and sexual behavior to fit HIV data and behavioral data. I know I've said that sentence very quickly, and obviously calibration is a very involved process, but I'll skip over the rest of the details for now. Okay, and then on top of this, we add a syphilis module where we vary the rate of decay of transmissibility post-latency. So how you should think of this is assume that we kind of know how transmissible people are in the primary and secondary stages, and then we want to we're looking at different assumptions for the relative transmissibility as they're in this box here, the early latent phase. So just to keep things simple, because we wanted to be able to get some simple answers out just by varying as little as possible. We just looked at kind of 3 different decay rates, looking at varying the half-life of latent transmissibility. So in one scenario, this is kind of how many months have passed since somebody's entered latent infection. In one scenario, transmissibility drops quite quickly. So within 6 months, they're half as transmissible. And then we vary that from 6 months to 1 year to 2 years so that we can see how much difference comes across as people remain transmissible for longer. Okay, and then the key questions that we ask of this analysis as we do this is, firstly, how would transmission patterns change? And secondly, how would the impact of a new diagnostic for active syphilis change? So active syphilis means in one of those first 2 stages, primary or secondary, where you have symptoms and are more transmissible. Very slow transitions. Love it. A lot of suspense. Okay, so the first result that I want to walk through here is kind of highlighted in the title here, right? So if we're looking at a scenario where we have rapidly declining latent transmission, then one of the first things that we found looking at this analysis was that this would imply a larger role for key populations and young people in driving transmission. So in thinking about this, if people are only kind of infectious for a shorter amount of time, then transmission is going to be more concentrated in populations who have a higher turnover of partners. Whereas if you have a longer duration of infectivity, because people remain transmissible during the latent phase, then this implies that transmission can happen also during kind of longer relationships of longer duration or stability. So here's 2 examples. I mean, there's a lot of results. I just kind of want to pull out the ones that are more kind of visually impactful. Two scenarios here where we vary that half-life of latent transmissibility, looking at 1 year or 2 years. In the 1 year scenario, then we can look at the proportion of syphilis cases that are transmitted from either female sex workers or their clients. And we find here that there's a larger role for transmissions that are driven by sex work compared to in this next scenario where people remain transmissible for longer. Latent transmissibility has a larger role. And in this case, we have around 36% of infections which are directly attributable to sex work. So this is more or less kind of what we were just saying. It was our intuition for what we would expect this to look like. And then we've got those those figures highlighted in that little table over there as well, alongside with the results for when we have a half-life of 6 months, in which case you have an even higher proportion of infections that are directly attributable to sex work. So one thing that you could obviously do, with more time and access to data and so on, is try to cross-validate some of these things with what you could find about incidence patterns within sex workers. And that would give you a little bit more insight about what you might expect the role of latent transmissibility to be. Okay, I know I'm almost finished, but almost out of time, but I'll just quickly go over the final kind of result here, which is, okay, so, the headline here is that if we had some sort of better way of diagnosing primary syphilis, this would be a more effective thing to have if most transmission was happening while people had an active infection. So remember, we looked at scenarios looking at, most transmission happening while people are active versus if latent transmissibility plays a larger role. Now, if latent transmissibility plays a larger role, then you won't get so much impact from having a better detection method for active syphilis. So that's what this kind of slide is calling out here. I won't go through all of the details. Suffice to say that this half of the slide outlines many of the problems with the current methods that we have for diagnosing syphilis. It's difficult to do. People show up with a genital ulcer and it may or may not be syphilis, so often those cases are missed. There's a strong use case for a better diagnostic for syphilis, particularly in primary stage, but the impact we would expect that to have varies a lot, which is what's shown over here, depending on whether we look at a situation where latent transmissibility declines very quickly versus if it declines more slowly. Okay, so I think this is my last slide, just some conclusions. Old disease, lots still to understand and get data on. And we used this co-infection model to see that we could get to highlight these very different epidemiological pictures that emerge depending on what we assume about how long people remain transmissible for. Just again to highlight the StarSim Learning Day and some other talks which are sort of related and use this StarSim architecture as well. And then just finally to highlight the role of the many collaborators that are involved in this work. This is an ongoing piece of work involving many collaborators and teams across the Bill and Melinda Gates Foundation, and then also externally. So the Alina and Ramesh from the Burnett Institute helped develop the HIV model that was used here. And then we had a lot of expert consultation from Michael Marks and Marcus Chen for developing the syphilis module as well. Thank you. Happy to take questions.
Thank you, Robin. Do we have any questions in the room right now?
When you considered different duration of infectiousness, did you normalize for the total infectiousness? Because your lines looked higher, so you have to normalize, right, to make a fair case.
Yeah, so this is part of what I skipped over, but so I put in these different assumptions about the duration of latent infectiousness, and then I still had to calibrate remaining parameters to give the same overall level of syphilis infections. So then I varied the relative infectiousness of the primary and secondary stages to match that.